Long-term treatment is difficult for everybody. For patients primarily, even the concept of having a plan for long-term treatment at the time when the patient is facing first-time discussion about diagnosis and plan for treatment is really hard to take. It seems like endless, and that is overwhelming and sometimes difficult. That, surprisingly to me, because I've been treating with extended treatment for many years, my patients, majority of patients eventually accepts this approach. If they have some difficulties with treatment, that is, of course, more difficult. But if they achieve good response, and if we either have good tolerability of treatment or we establish schedule and dosing which is tolerable, not more than mild toxicities. If they see why we do that, for the most part, they are able to stay in the program and continue on this treatment. But that's for most of the patients, I would say, or for majority of the patients who are tolerating treatment well, having good responses. There are still challenges which emerge even for these patients that are definitely for those who are having problems. If there are some emerging toxicities, difficulty tolerating the regimen, that's of course much more difficult to stay on treatment and in the program or plan of therapy. That may be variably resolved between patient and physician, depending what level of response it is, whether there is any way that we can limit those toxicities. The second difficulty is just, frankly, natural human way of being in this type of very hard lifestyle changing regimen, coming sometimes even 2 to 3 times a week to infusion area, and not only for 5, 6, 7 months, but for extended time, it is becoming harder and harder for many patients. Many of the programs take into account that potential difficulty and scale back in various ways intensity of treatment, which may be more intensive first 6 to 8 cycles, then becomes in an extended phase either once or twice a month visits in many of the current regimens, which is more doable. Still, it is probably the most common challenge for both patient and physician to continue treatment for extended time without even problems with this need for frequent visits and disruption of their normal life, especially if there are long waiting times, if there is a long drive to the clinic, especially on clinical trials. So no question that this is a challenge.
As the survival of patients has improved markedly in the last decade, going from a survival of 2.5 to 3 years to, at least in our data set, median survival has not been reached with 10-year follow-up. I think management of patients in the long term does become a bigger issue now. Clearly, the use of bisphosphonates indefinitely is starting to fall out of favor. And so going with a frequency of every 3 months after a year or two, and potentially stopping for patients that have long-term CR is an important thing to consider to reduce the risk of ONJ and other complications of bisphosphonates. The long-term use of maintenance therapy also becomes an issue. We have patients that have been on maintenance lenalidomide, say, for 10 plus years. And at what point can you stop maintenance lenalidomide? The use of MRD testing may help us to understand that, but right now we don't have good data to help guide that decision.